Thank you so much, BVI, for inviting me for this booth lecture. My subject today is selecting right patients for the premium intraocular lens implant. My name is Mayank Nanavaty, and I work in Brighton, United Kingdom. I am a cornea, cataract, and refractive surgeon. And these are my financial disclosures. The one which is related to this talk is that I'm a paid speaker from BVI today. Now, I'm going to give you an overall impression of how to select a patient for a premium lens, which includes a toric lens, or which can include an EDOF lens or a trifocal lens. The targets of any refractive surgery, because all of these are refractive surgery, would be to gain accuracy of your outcomes. Consistency is also very important. Stability is important over a period of years and maybe decades as well. Efficiency of what you do is extremely important, and safety is paramount. Now, before we go into details of the selection criteria, I want to give you an overview of what the procedures are for the patients in terms of selection of premium intraocular lens options. But it's important to know that there are other options such as corneal procedures you can offer these patients as well, if your premium lens patients are not happy. For example, surface ablations like PRK, trans-PRK, LASIK, LASAC, and so forth. Flap-based procedures are LASIK, obviously, and incision-based procedures are LRIs or PCRIs or acute keratectomies or keratotomies, lenticular extractions, and inlays. With regards to the lenses, you have got options of phakic lenses, refractive lens exchange, and cataract surgery. Now, there's a thin line between refractive lens exchange and cataract surgery if the patient is beyond the age of 65 years, because most of these patients will have some sort of lens ossification. These are my preferences in my private practice, but you may have your own actually. But these are based on the scientific literature, and as you can see here, this is based on the refractive error. So at the bottom, you can see -20 to +17.5 diopters of prescription for premium lens patients, and I'm talking about refractive lens exchange here or laser surgeries. But when we talk about the refractive lens exchange or phakic lenses, you can see here that RLE is applicable to almost the entire range of these patients from -20 to +17.5. And phakic lens obviously is a choice. And then if the patient is younger, which is this age graph here, then you can have laser options as well. Laser is not an option or subject of my talk today, but as you can see, this is an age graph. If the patient's older than, say, 50, 60, phakic lens or lens exchange procedure would be a choice. Now, let's go into details of what are we looking for in patients with refractive lens exchange or correcting astigmatism in these patients. We are talking primarily about patients who are 55 years and older, and we are talking about patients who need intraocular lens exchange of some sort, either cataract surgery or refractive lens exchange. To understand that better, I think we need to understand how the cornea is and the anatomy of the cornea. So you have 5 layers, just the basics to be cleared first: epithelium, Bowman's membrane, stroma, desmates, and endothelial cells. And you may see patients with comorbidities, and these are the commonest ones that you may see when a patient comes to you for correction of vision and premium lenses. You may find that these patients have blepharitis, ocular surface diseases. You may have patients with dry eyes, rosacea, keratitis, and so forth. And those patients need treatment with lubrication, warm compressors, doxycycline, even IPL treatments or tablets long term. If you don't take care of these problems beforehand, you may end up with unhappy patients and even risk of infections and endophthalmitis, which you don't want in these patients. So I think it's very important to look at these factors first before you deal with the vision correction issue. The other thing which commonly is seen in our clinics when the patient comes for lens exchange is subclinical subepithelial disorders, such as anterior basement membrane dystrophy. The same condition has also been called as epithelial basement membrane dystrophy or map dot fingerprint dystrophy. You see maps, dots, and fingerprints all across the cornea. Or you see recurrent erosion syndromes in some patients, and if you do see them, that needs treatment as well. And how do we treat that? We have to make sure the keratometry of these patients is very reliable, and sometimes they're not. You may find that the patient has got irregular astigmatism on topography and biometry scans, and to regularize the topography, I normally suggest delaminating the epithelium in such patients. And we have to counsel the patient that this procedure may be necessary just to make sure that the outcomes of the lens procedure, which you have later on, is much more precise. If the keratometry is not disturbed, obviously you can give lubrication, but if the keratometry is disturbed, alcohol delamination or a PTK may be advisable. This is just a brief video of PTK, which I think is not working. We'll skip that, but this is a LASIK well. We pour some alcohol drops in it and then remove the epithelium and do the procedure. The other thing which is underdiagnosed in most white Caucasian patients who come for premium lens procedures is subtle herpetic scars. They might give you history of red and sore eyes many years ago, and when you examine these patients, they will have some scarring of the cornea, which is very faint, and oftentimes these are herpes-related scars. And it's very important to counsel the patients about herpes simplex 1 and 2, because oftentimes when you utter the word herpes, they jump on the chair and say, well, no, that is a nasty disease, I never had that. But actually, you tell them that herpes 1 is always a commensal in most of us, and it can affect corneas very commonly. And the treatment would be antiviral drops, and make sure that you don't get reoccurrence of that. So this is a treatment. You never see patients with bilateral scars from herpes unless they're immunocompromised or have atopy. Atopy is where they have eczema, asthma, and hay fever. Very rare. So usually it's unilateral, and treat them enough with tablet acyclovir. You can also give ointments. Acyclovir ointments slightly more toxic in my personal opinion, but tablets are better. And then embark on the premium lens surgery. Now, there are stromal disorders of the cornea, and the stromal disorders would mean scars, dystrophies, and ectasias. Ectasias are common in keratoconus and post-LASIK patients. If you see edema of the cornea in these patients, then it can be because of several reasons. If you see a very localized edema, it may well be from herpes, which is called as disciform keratitis, or also labeled as endothelial keratitis. And that needs treatment with antivirals and steroids both together. So that needs adequate treatment. Counseling is very important because these patients may have problems with the keratometry. And so you have to tell them that if your flare-ups continue to happen, then you may not achieve the best outcome you are looking for. And that will lead to better outcomes for the patient because they will not be unhappy afterwards. Shingles or herpes zoster is getting commoner in younger patients nowadays. It used to be a problem of elderly patients only, but now we are seeing more and more young patients. And if they do, actually, they may present like this, which is terrible. You need to treat them first and counsel them about the outcomes, and ideally avoid using trifocal lenses in these patients because they do often get recurrence of these problems. Subtle findings such as, iris transillumination defects may actually point out towards the possibility of zoster or shingles in the past. So you do ask that question. If the patient says, I've never had injury, but on examination you find some issues with the iris, then you obviously conclude that this patient had previous history of shingles, and treat them adequately before you actually go for the premium lenses. Endothelial disease often missed actually by our colleagues because in the busy clinics they don't have enough time to look at the endothelium more in detail or do a specular microscopy. This is where the endothelial cell count is low, and the common presentations are Fuchs dystrophy. Subtle early Fuchs dystrophy can be missed in some patients, and you have a condition called as posterior polymorphous dystrophy as shown in the middle figure here, and the last figure, which is cloudy cornea, is rare in patients who are coming for premium lens because that's mainly a condition of a child. It's called as CHED, child seen with endothelial dysfunction as they're born. But Fuchs is very common, and if you do have Fuchs dystrophy patients, adequate counseling is important. And you can also offer them trifocal lenses in these patients if you are doing DMAC surgeries or endothelial surgeries on regular basis. I would not advocate that in normal patients or normal surgeons, because this does require additional expertise. I would suggest send to a surgeon who would be expert in dealing with cornea and refractive procedures. The second condition, PPMD, posterior polymorphous dystrophy, just appears like a scar or snail track. That doesn't actually change the plan of the surgery, because it hardly affects the vision, hardly affects the outcome of the procedure, so you don't have to bother about that. Just warn the patient that you do have scar, which people might notice in future. If you do embark on surgeries with Fuchs dystrophy, this is what you end up with, which is edema or swelling of the cornea, which makes you and your patient very unhappy. So very important to counsel the patient about this. And when you refer the patient to a corneal surgeon, this is what they do basically. This is, I have done this very regularly. This is, by the way, it's an off-license use of trifocal lens. Most of the companies, including BVI, will not promote using a trifocal lens in corneal conditions. But because this is an educational talk, I'm just going to give you a brief overview of what we can do in such patients. I'm just going to skip this video as fast as possible, if I can. Anyway, I can't fast forward this video, so I'm going to skip to the next slide. Essentially, this is a combination of trifocal with a DMAC. And we published this in Journal of Cataract and Refractive Surgery a few years ago, and very soon we are going to publish some evidence of using extended depth of focus lenses with Fuchs dystrophy as well. Again, as I mentioned, as this is American Society of Cataract and Refractive Surgery, these are off-license uses of premium lenses. Most of the companies will not promote using that in corneal conditions, but if you deal with cornea, then it may be an option for your patients. With regards to the refractive lens exchange options, you need to know about the monofocal intraocular lens, how they actually provide spectacle independence, not just for the distance, but also for near. You can give mini monovision or monovision with monofocal lenses or enhanced monofocal lenses, or you can use multifocal, which is trifocal lenses, but there is a bit of a trade-off in terms of giving more dysphotopsia with trifocal lenses, depending on your patients. In my practice, patients do come with high demands of near vision spectacle independence and almost seek for a guarantee for that. And if that's the case, I would suggest trifocal and counsel them heavily about rings around the headlights when they drive at night. And if you tell them 3 or 4 times before the surgery, they will expect that and therefore not be very annoyed with those symptoms. Whereas with the mini monovision or monovision option, I find it that sometimes if the patient hasn't had that trial with a contact lens before, they may not like that, and if they end up with not liking that scenario afterwards, it may be a problem because they have to rely on contact lens glasses or laser vision correction. What I mean by monovision is where you target one eye for distance and the second eye for whatever activity they would like to prefer. Not necessarily the near vision. It could be near or intermediate vision, whatever they want to prefer. The other point is to consider correcting astigmatism as much as possible. Premium lenses obviously give better and more precise, accurate correction of these astigmatic patients. I would suggest using toric lenses if you're using trifocal lens beyond 0.5 or 0.75 diopters of astigmatism. Some surgeons believe that they should not correct astigmatism up to 1 diopter because surgical induced astigmatism can compensate for that. We did a study on this, which I'm going to briefly mention that as well. But as I mentioned, there are several techniques to diagnose astigmatism before you plan the surgery. And on the day of surgery, there are several techniques available in the market where you can mark the axis of correction of the astigmatism. But we use a simple surgical marker, which also works very well, as long as the tip of the marker is not very thick. You counsel the patient to put some drops in and mark the axis at 0 and 180. And once that is done, that it becomes your reference mark, and then you can correct the astigmatism. If you're using toric lenses, you need to be aware of angle kappa issues intraoperatively. These are the 2 videos, and basically what this video is showing is implantation of toric intraocular lens. You will have marks of toricity on the lens, and when the patient is looking at the light, this is under topical anesthesia, by the way. I consider topical anesthesia as the best choice to correct astigmatism because there's no intorsion related to subtenon or peribulbar anesthesia or general anesthesia. So when the patient is looking at the microscope light, you will find that the light reflection, the Purkinje images of the light, may not be in line with the axis of the lens. And if that's the case, the patient has got angle kappa. So you can then counsel the patient post-operatively about possibility of some visual disturbance because of the angle kappa issues. And this is more relevant in patients with multifocal lenses than with simple monofocal lenses. I'm not able to drag the video near the end, so I'm going to skip the video of it. But angle kappa is an important factor which needs to be looked at beforehand as well. Some of the latest biometric machines are giving you this information when you do the lens calculation, and I think that's important to consider, especially when you're using multifocal toric lenses. Limbo relaxing incision has been in our practices for 2 or 3 decades and is getting better and better. However, they're still not as precise and as accurate and reliable as toric lenses, but they work very well under the 2.5 or 3 diopter range, because beyond that they don't work very well as the incisions become very large. There are several blades available in the market to do that. You can use guarded blades or non-guarded blades or diamond blades, but these are examples of guarded blades where you have a guard, which is shown in the figure here. This guard protects the blade from stabbing the cornea at full thickness, and it only gives you the depth you want in these patients. And this is how we do it. We mark the axis as I showed you in the picture before, and then in one go, without raising your blade, you just do the correction. Now, to plan the incisions, there are softwares on the websites. Several software. I use one called as lricalculator.com, but there's similar softwares all across you can use in such patients. But this procedure doesn't work very well if the patient has more than 2.5 diopters of astigmatism. So we did a study to look at whether the toric lenses are better or the incisions are better if we correct patients between 0.75 and 2.5 diopters of astigmatism, and we found that toric lenses do perform better in these patients. In other words, using toric lenses, if you have a choice, would be a best choice in comparison to incision. Now, since past a few years, we have moved on with the technology, and we now use enhanced monofocals and extended depth of focus lenses, and that has created a bit of turbulence in the market because people are combining the concept of these lenses with mini monovision and spectacle independence in a similar way as the trifocal used to do. But it's very important to understand the difference between these lenses. The ESCRS has also published a statement, which I concur with, that in past 2 decades, all of us have moved over to using more intermediate vision than near vision because of our phones, iPads, iScreens, and laptop works. We read less and less books in the physical form. We read more on the screens nowadays compared to reading material in physical form. So therefore, intermediate vision has become more important nowadays. Broad classification of the lenses. Nowadays, it's very important to understand this before you offer this options as spectacle independence option to the patient. Is monofocal lenses, which are conventional lenses, enhanced monofocal lenses, as you can see here, iHands, Isopure, EMV, etc. EDOF lenses, so many of them. Extended depth of focus lenses are the ones which gives you distance and intermediate vision. They can be diffractive or refractive design lenses, and trifocal lenses could be fine vision, panoptics, and so many others in the market as well. So once you understood this, then it might be easier for you to titrate the options for your patients. Don't think about the monovision when you are understanding the lens concepts, and once you understood the lens concept, then obviously you can offer them options of monovision if you want to. And remember, there are horses for courses, which means not one lens will work for all the patients, and all the patients may not be eligible for the same lens. So you may have to pick up between the lenses of your choice. The other thing which is very important to understand for ophthalmologists nowadays is the defocus curves, which has come into market in the clinical market since past 10-15 years. since the introduction of these trifocals and bifocal lenses. Now, when you're presented with a graph like this, with one peak, that means the patient has got good vision for distance only. When the peak is stretched, then that means the patient has some enhancement of the monofocal vision, which means the patient can also have some intermediate vision alongside distance. If the patient has clear two peaks, then the patient has got an EDOF lens, or the lens is an EDOF variety. And if it has got three peaks, then obviously it's a trifocal lens. Now, the problem here is different companies will have different graphs, and based on the graphs, you can judge which distances are more prominent or more effective in these patients. And based on your judgment on these graphs, you can then titrate the option to the patient and say, well, I can give you an EDOF in one eye and trifocal in the other, and so forth. Multifocal lenses are a broad term, in my opinion, because multifocal lenses can be anything really, including the EDOF lens can also be classified as multifocal because there are more than one focuses. Factors which you consider before offering any kind of multifocal, which includes EDOF or trifocals or bifocals, would be the age, the needs, lifestyle, the psychological factors, clinical conditions, as we already gone through, the pupil size, reactivity, how they drive at night, whether they drive at night or not, evidence from the published literature, and also evidence from your colleagues, which is what I rely on in these kind of conferences. I would normally go and speak to the colleagues who use these lenses and get some education firsthand from them. And the surgeon's attitude, education, and the experience of using similar lenses in the past also counts a lot in terms of offering the options. Now, as I mentioned earlier, multifocal lens is a broad term, and it can be divided into refractive, diffractive, or segmental, and it can also be divided into, say, EDOFs and trifocals or bifocals based on what they offer. Simple principles of optics apply to these lenses: refraction, diffraction, and reflection. Won't go into details of the physics principles here, but basically they turn the light into different points. The other basic concept which we all should know is that the lens has got diffractive rings either in the front or the back. Most of the lenses will have the diffractive rings in the front of the lens, but you need to check that with individual companies. The power of the lens, which is, for example, 20 diopters or 21 or 22 diopter power of the lens, would normally be on the posterior surface or the back surface of the lens. But again, that needs to be confirmed with individual companies, but most of the lens companies would have it on the back surface of the lens. The diffraction rings are on the front surface usually. With regards to the rings, the basic concept is you need to know the length and the height. The length, which is shown in this figure, will indicate the add power, which means whether it gives you +1, +1.75, +3, or so forth. The height of that ring will give you the strength of the light at that power. So, for example, if it's the length suggests +1.75, the height is too high, which means the power or the light intensity at that point is quite high. And that's very important to know based on the different designs of lens. Despite of understanding all these things, you will encounter patients who will not be very happy with what you have offered, and it's very important to then know how to deal with these patients as well. And the major issue in most of these patients who are unhappy is a mind gap between what you have explained to them, what they have understood, and what their expectation is. Sometimes, despite of explaining everything to the patient, they would not take everything inside, and therefore the expectations will be high, and despite of counseling them heavily, they will not be happy. These issues are often encountered because of lack of soft skills from the surgeons or the team which you're working with. They're quite mechanical sometimes. They work with technicians, receptionists, junior doctors, and I think you need to train your team just to ensure that the patient is listened to and the patient is given all the information they are supposed to know before the surgery. A lack of time on the patient side. Some patients come in hurry. They want surgery yesterday. And that's not possible. I ask them to at least think for at least 2 weeks, if possible, after the initial consultation. We also write letters to the patient explaining what the diagnosis and what the options are. And if the clinics are too busy, that needs to be addressed. You need to have enough time for each patient. Too busy surgical list also actually puts the surgeon under stress, and that can create problems such as surgical complication, which can be an issue. Major factors which can affect the outcomes are astigmatism, as I mentioned. Won't go much more into details now. Cornea and ocular surface, we already mentioned that. Centration of the lens, I've touched that slightly on the angle carpi issue. Capsular bag issues, cystoid macular edema, and sometimes the temperament of the patients, or surgeons either. So astigmatism, you need to know your own surgically induced astigmatism. When you do the keratometry or topography on the machines, you need to know the difference between topography and the machines. You also need to know whether the biometric machines gives you a wider zone of keratometric assessment or not. If not, you may have to use topography assessment and then plan your astigmatism correction. It was known that every 1 diopter or 1 degree of toric misalignment can cause 3% undercorrection or overcorrection. However, I think this philosophy is now refuted, and in the clinical experience, I find that up to 5 degrees of misalignment may not affect the outcomes hugely, but that also depends on the amount of astigmatism the lens is correcting. If it's mild, then you may be fine. If it's a high diopter astigmatism correction on the lens, then it may not be fine. Obviously, if the patient still ends up with some undercorrection or overcorrection, you do have options such as glasses, contact lens, excimer laser, and exchange of the lens. Ocular surface disease, I won't go into details, we just touched upon them. But plan your incision very carefully. I normally don't change my position of the incision based on the astigmatism, because I use toric lenses in these patients. Some patients do on-axis incisions. I think that is a good idea, but that makes you sometimes uncomfortable if the angle of the astigmatism is at a different place. Suturing, if you suture your incisions, then use nylon instead of Vicryl, because if you use Vicryl, which is a dissolvable suture, then you end up with fixing the astigmatism from the suture. But if you use nylon and if you remove it within a couple of weeks, then you don't fix the astigmatism. So using nylon is better for suturing of the wounds. Intensive treatment of the ocular surface, we have been through before. Now the second issue is centration. I touched upon that on the angle carpi issue, and we published a paper on decentration and tilt and its effect on visual acuity, dysphotopsia, and aberration. Using aspheric lenses can lead to some issues if they are decentered in the capsular bag. But it also depends on whether the lens is having any spherical abrasion correction in the center for the EDOF benefit, or whether the lens has got rings in it. So multifocal lenses and EDOF lenses may have more issues if they are decentered significantly in the eyes. How do you check the centration intraoperatively? As I've shown you with a microscope light, you can do that. You can also ask preoperatively questions about amblyopia, which is the laziness of the eyes, or prisms. Oftentimes the patients won't mention the prisms they are wearing in their glasses, and if they do actually, then that can be a red herring or a red flag in offering any premium lens correction. You need to counsel them about possibility of needing prisms after the surgery as well. Can you correct any centration of the lens if you know already that the patient has got angle carpa? Answer is no, clearly, but to some extent you may be able to do that by using a capsular tension ring. But if you use a ring in high myops, sometimes you may end up with a different effective lens position affecting your refractive outcomes. But there's some evidence that hydrophobic lenses stick better to the capsule, and that sticking better to the capsule property of the lens may be beneficial if you center the lens on the right axis during the surgery. Post-operatively, if the lens is decentered and if the patient has, say, for example, an EDOF or multifocal lens, they might say the vision is excellent, 20/20, but I feel like a Vaseline vision or slightly misty vision, and that may be a sign of a decentration. And then you look at the pupil and the centration of the lens. There are several things which people have suggested in literature, such as using pilocarpine or brimonidine to constrict the pupil. Whether it works long term, yet to be seen. There are no long term studies on this, but in short term, it does work until the patient gets neuroadapted. And there's anecdotal evidence of using argon laser for that. I personally don't have experience with using argon laser in these kind of cases, and most cases will settle down with neuroadaptation. With regards to the capsule properties, you need to know whether the patient has got any cataract before you offer the premium lens, and if they do, actually whether the cataract has got posterior subcapsular element. Oftentimes, thick posterior subcapsular cataracts may have thick, dense capsular plaques or thickenings, which may need YAG laser capsulotomy before the final vision is achieved. And if you counsel the patient that you may need a laser procedure done after 3-4 months to give you the final vision, then the patient would be quite considerate. If the patient doesn't know that the vision will not improve straight away after the lens procedure, then it may be a problem because they're not informed prior to the surgery. Also, look for a pseudoexfoliation when looking at the capsule. Look for any dialysis or dehiscence or subluxation that can create problems with your premium lens surgery. If you end up with problems during the surgery with, for example, a PC tear or posterior capsule break, then you can still use a premium lens as long as you do a decent vitrectomy and place the lens in the right place, which is in the bag, and the tear is not too big. If the patient has had to have a toric lens, then it may be a problem because the tear may not allow you to place the lens in the right orientation. You can also capture the optics of the premium lens, which is reverse capture with the haptics in the back and optic in the front, and vice versa, based on the situation you're in using a premium lens. With regards to the YAG laser capsulotomy, I would normally wait for 3 months because doing capsulotomy prior to that can lead to high risk of detachment, tears, and holes in the retina. And if you're doing capsulotomy in patients with premium lenses who is not very happy, it may be advisable not to actually do a large capsulotomy in case if you have to go back again to exchange the lens in future. Now, this is a very important property, which is cystoid macular edema, which is often a problem in patients with premium lenses. This is because the pre-op assessment of the surgeon doesn't include routine OCT scans. There's enough evidence now that apart from the biometry, one of the mandatory scanning should be OCT of the macula in all these patients. I think topography is probably going to be the next one, which is mandatory in these premium lens patients. We did a study in Brighton looking at a few hundred patients who were going for cataract surgery, and we did OCT scans on all of these patients. We found that about 4% of the patients who had epiretinal membrane before the surgery were missed just on looking at the fundus assessment. So just examining the fundus with a 90 or 78 diopter lens will not rule out the possibility of subtle epiretinal membranes, which can lead to cystoid macular edema or distortions or problems with the visual outcomes afterwards. So we have now got a mandate that every patient going for any lens surgery should have an OCT scan along with the biometry. If you want to avoid cystoid macular edema when you are aware that the patient might have this, then avoid anterior chamber fluctuations, do slow motion phaco, and if you do get cystoid macular edema despite of your best efforts, obviously we know how to treat that, topical steroids with non-steroidal anti-inflammatory. And if it still doesn't settle, then you may have options of referring the patient to the retinal colleagues or give further devices or injections in the back of the eyes. And the final point is craziness of the patient and the surgeons both. And I think most of the times is the expectation issue, as I mentioned earlier in my presentation. If the patient's expectations are high, then I would say under promise, make sure that they are aware of all the risks and make sure they understand what they are having in great details. I would also counsel the next to kin about the aftermaths. The increased chair time will lead to decreased unhappiness afterwards. Pre-operative counseling includes all of these things which are on the slides, includes glare and halos, dysphotopsia, risk of undercorrection, overcorrection, refractive procedures later on, posterior capsule plaque, opacification, YAG laser capsulotomy, retinal complications which may need further procedures, further procedures to exchange the lens or piggyback, and neuroadaptation if you're going for a multifocal lens. Talk during the surgery. I find that very helpful. If you talk to the patient at the time of surgery, explain them each and every step. They are aware of what's happening rather than being anxious and panicked about what's the happening. And sometimes surgeons ask the staff to not talk and be very quiet, and that actually tends the patient. If I'm the patient, I want my surgeon to talk to me. So I think talking to the patient does help. And finally, post-operatively, if the patient still remains unhappy, give them enough time to talk to you, listen to them, don't interrupt, and don't discharge or dismiss them. Try to answer each and every concern they have, and then do the needful to improve the outcomes of the patient. And these are the list of other complications which the surgeon and the patient should be aware of, which we already covered during the presentation. So thank you so much.